Okay, so let's start. Bismillahirrahmanirrahim. Sorry for the late. Let's start it, the dermatology today, inshallah. Let's start with the first case. This is the child with the blistering rash. Okay, so this is a TAS part and taken from the TAS chapter, TAS clinical cases book. The case is the 9-month-old boy presented with the blisters over his neck and the left arm. Okay, before going to talk about this case, I would like to mention that I have shared the statistics notes with you people. I've also shared the dermatology notes along with the lecture. So just the lecture and the relevant cases from the FOP and the task book, and along with the dermatology notes, which I shared separately, that would be your resources for covering the dermatology part. Okay. So this is the case, first case. We are discussing a 9-month-old boy presented with the blisters over his neck and left upper arm, which appeared abruptly and have persisted over the last week. Initially, these lesions were just a pink patch. These evolve over 48 hours, then become a blister. Older lesions heals with crusting without any scarring. So over here, we are talking about actually the blister bullous lesions, okay? And we will discuss soon that the blistering is, we have to define the level in the skin that from where the blisters are arising. So some blisters are superficial, so they will not lead to any scarring. And some are the deeper ones that could lead to scarring. That is why they're asking in which layer of the skin the pathology is occurring that leads to a blister without scarring. So when we talk about, in this case, in which layer the pathology is occurring, so what you will going to see over here, these are the different layers of the skin are there, okay? So we will going to discuss first the little bit anatomy of the skin, and then you can see they are also asking sometime in detail as well that classify the layer of the skin in which actually the problem is arising. So we will back to the answers of these questions soon. Okay, there are different bullous disorder condition, bullous like disorder conditions in front of you. So first we will review the little bit lecture, and then we will solve the answers of these questions. Okay. First of all, when we talk about the skin, overall, the skin constitutes almost 1/6 of your total body weight, and major it has 4 important functions. Protection, okay, so because it's give us a layer, so that is layer is against the ultraviolet layer, mechanical, thermal, and chemical insult. It provides a physical barrier, so there will be no chances of invasion of any microorganism into our body. Sensation, so we can sense through the skin. There is a thermoregulation as well, that through our skin, under the skin, we have, adipose tissues as well. So they will help in maintaining our body temperature. So heat loss is facilitated by evaporation of the sweat from the skin surface and increased blood flow through the rich vascular network of the dermis. The fourth, which is very important, that our skin play a very important role in the conversion of the cholesterol and vitamin D synthesis. So these are the 4 important functions of the skin. Okay. Now we talk about the very important part, that is the layers of the skin. So if you will going to classify the broadly the skin, so we have the epidermis layer. So first of all, we talk about this is, yes, first of all, we'll talk about a big picture. Okay, so we can see over here that our skin, first of all, we have the most superficial part which can be visible. It is the epidermis. Then below is, you can see this greenish, this pinkish part. Yes, this pinkish part is of dermis. Then below the dermis, we have yellow part, subcutaneous tissue, and then we have the muscles. So we have total these skin layers. And now we will going to break further epidermis into multiple layers. Okay, so now we talk about over here especially when we talk about these different layers like stratum corneum, lucidum, granulosum, spinosum, basal. These all are the layers of the epidermis we are talking about. Okay, so the skin epithelium changes occur, and you can see the epithelial changes, that how the cell is changing his shape as he going outwards towards the surface. And if you look at the most superficial cells, they are completely flattened and elongated as compared to the basal cells and the other layer cells, which are rounded in shape or cuboidal in shape. So they will going to completely flatten out. They will lose their nucleus as well. So you can see in the corneum layer, the most superficial layer, it does not contain any nucleus as well. Okay, this is achieved by, so why these changes are occur? This is achieved by, these cell changes are achieved by the cytoplasm with the special protein keratin and cross-linking of these polymer fibers into strong, stable network. So what happened, that why these changes are occur? So if you look over here, that these cells will going to be the pink cytoplasm, the most superficial cell layer, which is pink stratum corneum, that is completely the cytoplasm filled with the keratin. Okay, and the squamous shape means the skin is resistant to mechanical traumas and allow shedding of the skin without disruption of the whole surface. Okay, so they are telling you why it is a squamous. So this flattened shape is called actually the squamous shape. Okay, so we have keratinized, because keratin is inside in our skin, so we have keratinized squamous epithelium in the surface. Okay, and when we talk about the lining of the esophagus, that also stratified epithelium, but that would be non-keratinized. Okay, so be very clear that keratin is present in our skin. Okay, now, okay, another important thing over here, now you can clearly look over here. This is our stratum corneum. Okay, now in this picture, you can see that only 4 layers are visible and the stratum lucidum is not there. If you see the previous picture, this gray one is the stratum lucidum. Okay, so stratum lucidum is only found in certain skin. Okay, like for example, your palm, your sole skin, which is very tight skin. Okay, so that will be found only in certain region, the lucidum part. Okay, other mainly we found this corneum, granulosum, spinosum, and basal. Okay, if you look at closely, a little bit close, if I can just a little bit zoom it for you, you can see it in the granulosum layer. The multiple granules are there. Okay, so the you can remember this layer, and it has multiple small bluish color granules are there in this layer. This is called stratum granulosum. Okay, now, if you look at the other, now again, you can appreciate the granules, bluish granules over here. Corneum, we have already talked about that corneum does not have any nucleus in it. Granulosa are having these granules in it. Okay, and now when we talk about these different cells, how they are connected to each other, that is also very important. Okay, so we have 2 types of connection over here. You can see one is called desmosome and the other is called hemidesmosomes. Okay, so when you talk about the desmosome, desmosomes are the cell adhesion structure. Okay, that are especially prominent in the epidermis and in the mucous membrane. So all this bluish color, this bluish color, this bluish color, all this attachment of the cell is basically because of this protein called desmosome. And you can see over here, especially the hemidesmosomes is the one which is connecting specifically the basal layer to the basement membrane. Okay, so the basal layer is the source of the new epidermal cell. So this last layer is basically is the one which is regenerating, and retipegs ensure the attachments of this dermis to the epidermal via basement membrane, and each cell is bound to basement membrane by hemidesmosomes. So this is hemidesmosomes are the one which connects those basal cells with the dermis. Another important thing is that in the basal cells we have called retipex. So what is actually the retipex is retipex, like for example, let me draw it. I don't have a picture right now. You can search it, but I can give you the concept that from the epidermis, these type of substances structure will invaginate into the dermis. Okay, these are called retipex. So they will going to further anchoring the epidermis with the dermis. Okay, they help in the attachment. So these are the, in that way, the epidermis will be attached to the underlying dermis part. Okay. Now we talk about, okay, retipex, hemidesmosomes we have talked about. Okay. Another thing, damage to epidermis alone. So if there is a damage to the epidermis alone, will lead to the blister formation. And if you have a damage in this part of epidermis, it will heal without scarring. Okay. While damage to the dermal layer or epidermal junction. So if it's involved your epidermal junction or your dermal layer, that will lead to the scarring. So that would be very specific. Our first question was related to the that our lesion was without scarring. So now we are very, very clear that our lesion is on the epidermis. Okay. If it is involving the dermal part, if it is involving the dermoepidermal junction, if it is reached to the subcutaneous, if it is involving entire epidermis and dermis, that all will lead to the blisters that would heal with the scar formations. Okay, so when there is only in the epidermal involvement, then there will be no scarring. Okay, so the epidermis is supported and nourished by the thick layer of the dense fibroelastic tissue called dermis. So in our dermis, we have basically the vascular capillaries are there. In our epidermis, we don't have specifically the the vessels are there. So this epidermis is getting nutrition from the dermis, okay, which is vascular. The dermal part is the vascular, contain many receptors as well. So the dermis is attached to the underlying tissue. So now this dermis is attached to the underlying tissue by a loose tissue called subcutaneous layer or hypodermis, which contain the variable amount of the adipose tissue. Okay, now in this chart, you can see that it's a very busy chart taken from your book, and you can see that so many conditions are there written over here, and they have manifest the pathogenesis as well, that which layer are basically involving and whether they are associated with scar formation or not. Okay, so this chart is very, very, very important. They specifically ask about the level of the lesion. Okay, so, okay, so we will talk about this chart soon. First, we'll talk about, a little bit in detail, and then we will go through that chart in the last, okay? First of all, when we talk about the staphylococcal skin infection, okay? Staphylococcal skin infection is basically, it's a three major blistering disease which affects the only epidermal skin layer. So you have to remember three important conditions that will going to involve only the epidermal skin layer. So if it's only involving the epidermal skin layer, that will be healed without scar formation. The one is called the bullous impetigo, the other is called staphylococcal scalded skin syndrome, and the third is the pemphigus. Okay, pemphigus. These three conditions will affect your epidermal skin layer. Okay, although the cause of these conditions are very different, but the underlying mechanisms overlap and account for some of the apparent clinical similarities seen between these rather different diseases. Now, staphylococcal scalded syndrome, when we talk about SSS, triple S, staphylococcus, okay, not the triple is 4S, staphylococcal scalded skin syndrome. In most of the time, it is common in the infants, okay? Especially it is common to the infant children's, okay? The blisters in the bullous impetigo and scalded skin syndrome are both caused by toxin mediated, okay, by the staphylococcus. So it is basically a toxin mediated lesions are there. We have two types of toxins are there. Toxin A will produce locally disease, that is in case of bullous impetigo, while toxin B will going to circulate throughout the body and will cause blisters throughout the body in a distant from the infection site. So typically what you will get the history in the staphylococcus scarlet syndrome, that there will be the red umbilicus. So the source would be the umbilical, but you will get the skin peeling and blisters in the limbs as well, in the trunk as well, in the back as well. So in the distant region, also the peeling of the skin will going to occur, okay. Both of it is mediated by the toxin, and what is actually they are causing problem, the level of the lesion is your desmosomal involvement. So we just talk about the desmosome protein, okay, which is connecting the epidermal cell layers. So it will going to act upon the desmosomal protein, specifically called desmoglin 1. So it will cause intraepidermal cleavage. So intraepidermal cleavage means within the epidermis, the cells will going to break down because their connection will going to be involved. Desmosomes will going to be break down. So the intraepidermal cleavage will occur, and which specifically involve the superficial layers of the cells. Okay, in these regions, the major adhesion molecule is the desmoglin 1. All type of staphylococcal infections are most commonly seen in the newborn infants and young children as immunity is less well developed. Okay, usually the lesions begin as a vesicles that rapidly enlarge to form a flaccid bullae. Lesions may vary from few localized to numerous, widely scattered with the title or no surrounding erythema. Pathognomic finding of bullous impetigo is the ring of the scale at the periphery of the eroded lesion with varnish surface. Staphylococcal cocci are isolated from the skin lesion of the bullous impetigo, while these are sterile in the staphylococcal scalded skin syndrome. So what is actually the meaning is that the in the bullous impetigo, because it is causing localized infection. So if you culture the bullous impetigo, okay, this you take the scraping or skins directly. If you scrape the bullous impetigo skin, you can directly get the staphylococcal organism. But if you will going in case of staphylococcal scalded syndrome, if you go to the lymph lesion and just break the bullous and take out that fluid, that would be completely sterile, that would not have any staphylococcal in culture organism in it. The fluid would be sterile in case of staphylococcal scalded skin syndrome. In the bullous impetigo, the fluid will not be sterile. You can culture the staphylococcal organism. But on the other hand, in the triple S, there will be sterile fluids. It is toxin mediated on the distant site from the infection. So you need to take culture for the from the different side, like you need umbilical cultures, you need nose culture, ear culture, wherever you are suspecting the staphylococcal infection is there, you need to take cultures from their site. Okay, the bullous fluid will be sterile in case of staphylococcal scalded skin syndrome. Now when we talk about the pemphigus, this is the third condition when we talk about, which involves the epidermal layer, pemphigus. Okay, we have two types, the pemphigus foliaceus and the pemphigus vulgaris. Okay, both is the autoimmune disorders, okay, which results from the production of the anti-autoantibodies, IgG, autoantibodies against the desmoglin 1 and the desmoglin 3. Okay, so what happened basically, the desmoglin 1, the former means that pemphigus foliaceus result in the superficial blistering, but when we talk about the vulgaris, it will affect the deeper layer of the epidermis, which is stratum spinosum. So if you know the order, Initially, the lowermost epidermal layer is the basal layer, then we have the spinosum, then we have the granulosum, then we have the lucidum, and last is the cornea. Okay, so this, the pemphigus vulgaris especially involve the stratum, spinosum, and mucous membrane, as in these region there is much more desmoglein 3 expression and much less desmoglein 1. So desmoglein 1 is mostly involving the superficial layers, which is in case of bullous impetigo as well, which is in case of staphylococcal scalded skin as well. But when we talk about the pemphigus vulgaris, which is actually antibodies against the desmoglein 3 protein that is involving the deeper layers of the epidermis. Okay, so this is actually a very good picture. It will tell you about the different lesions, how, occurring. Okay, so if you look at this picture very carefully, that this is our last is our basal layer. Okay, so this cuboidal shape is our basal layer. Okay, and you can see over here that below is our basement membrane. Okay, so this basement membrane is shown with the blue in color. Okay, and below the basement membrane, we have these encohering fibrils are there. These U-shaped encohering fibrils are there. And under it, we have type 1 and type 2 collagen is there. Okay, so this is all about the structure if we talk about little bit in detail. And where is hemidesmosome? So if you look within the cell, these are small. So if I just a little bit zoom it for you, now you can see this basal layer. The basal layer contain these rectangular shape, these connections. These are called hemidesmosomes. Okay, so hemidesmosome, this is your basement membrane. The basement membrane has two parts. The one is the lamina lucida, the above one. The bluish part is called lamina densa, which is a basement membrane. Then we have a connecting fibers, which is called encohering fibrils, and underlying we have the collagens. Okay, now where we have tonofilaments. So you can say the tonofilaments are the one which is responsible for the keratin formation, and these greenish tonofilaments are present in our last basal cell layers. Okay, so now what happened that different levels we have lesions will be there. So if you have abnormal tonofilaments are there, you can see if there is abnormal tonofilaments are there, then that can also damage our basal cell layers. Okay, so you can see that the tonofilament is basically a structure protein, or you can say that gives strength to the cell. Okay, so if for example, if you don't have a bones in your body, then your whole body will going to collapse. Okay, so just like the bony, a hard part, the tonofilament is a structural protein that will give strength to the cell. So if it will not be there, the cell will going to damage, and it will lead to the intra, that means not inter means with the between the connection, which is called intra means with the whole cell, within the cell. So it's an intraepidermal blister formation will occur. The cell will going to damage. This is called epidermolysis. Okay, this is called epidermolysis. Sometimes blisters are occur in which condition is associated with it? The condition epidermolysis bullosa. So now we talk about the three important condition previously, which is in affecting the only epidermal part, which was pemphigus, staphylococcal scalded, bullous. We have talked about that part is over. Now we talk about the other conditions, the bullous disorders like epidermolysis bullosa simplex, junctional epidermolysis bullosa, and the dystrophic epidermolysis bullosa. So you should understand the level of the lesion. So in the epidermolysis bullosa, actually it's the involvement of the tonofilaments that leads to the intraepidermal blister formation. Okay, so the last layer, the basal layer, will going to be involved over here. When we talk about the junctional cases of epidermolysis bullosa, as I mentioned, whenever there is a junction is involved, it will lead with the scarring formation, okay? So junction, if it is involved, you can see that the blisters in the lamina lucida layer, okay? And when we talk about the dystrophic epidermolysis bullosa, it's basically the subepidermal blisters, okay? So you can see this is your epidermal, the tonofilaments is anchoring fibrils, the U-shaped fibrils are involved. In the case of junctional epidermolysis, it's the hemidesmosomes is involved. That is why the cell will lose its connection from the basement membrane and you will have a blister formation occur. But if it's anchoring U-shaped fibrils are not there, that will lead to the subepidermal blisters, and that is called dystrophica epidermolysis bullosa. So dystrophica epidermolysis bullosa, it's a junctional involvement. Junction itself, it's a junction, so both will lead to the scarring formation. When we talk about the epidermolysis bullosa simplex, it's the basal layer of the epidermis will going to involve, so unlikely they will not cause any scarring formations, okay? Okay, now we talk about, so we talk about the important, now we go through that important chart to revise the important things, okay? Okay, so this is our important chart. Okay, so if I'm just going to summarize this chart for you, so we have already talked about the initial three conditions, if you can recall, okay? Bullous, staphylococcal, pemphigus. Pemphigus were two, pemphigus foliaceus and pemphigus vulgaris. Okay, so over here, there is pemphigus vulgaris is over here. Okay, so pemphigus, pemphigus foliaceus, pemphigus vulgaris. I've already told you the foliaceus pemphigus, it's the desmoglin 1 is involved. The superficial epidermal layer will going to involve, and that will leads to intercellular, means between the two cell the desmosome protein is involved. That is why it is intercellular, between two cells, okay? Next is the vulgaris, again antibodies, which is desmoglin 3, deeper layer, especially the spinosum, and again it is intercellular between the two cell, okay? And both, because it's epidermis, so there will be no scarring, okay? So you just need to remember the level is very important. They specifically ask the level, that is why I'm focusing on it, okay? Now, when we talk about the bullous and the staphylococcal, so in the bullous also, you can say it is a toxin mediated, confined to the site of infection, so localized, okay? And staphylococcal scalded, it is again toxin, but that leads to the distant site, remote site, and separation of the superficial. So again, they are involving the superficial layers, both are involving the superficial layers without any scarring formation. Another condition I talk about, the epidermolysis bullosa, if you can remember that in the bullosa, we have tonofilaments are involved, okay? And it's the intraepidermal, the cell break is occur, okay? It's the inherited, mainly autosomal dominant. Cytolysis, the cell breakdown is occur. It's caused intra, it's not inter, it's not the connection problem, it's the structural protein, the tonofilaments are involved. That leads to the intraepidermal skin in separation in the basal or the spinal layer. But because these are the epidermal layers, so there will be no scarring. So just you need to remember. Now, when we talk about the junctional, okay, and we just talk about the junctional and the dystrophic, what we talk about in the junction, it's the involvement of the hemidesmosome dermoepidermal junction, okay? So that is why it leads to the variable scarring is there, okay? So it's variable scarring is there. Now, when we talk about the another condition, which is called dystrophic, this is the dystrophic epidermolysis bullosa. We just remember it was below the dermoepidermal junction, which is the involvement of your the fibrils, the U-shaped fibrils. It was below the the epidermis, below the dermoepidermal junction, again, it will lead to the scarring formation. Okay. Now, when we talk about the pemphigoid, what is the pemphigoid condition is this? Pemphigoid is directly antibodies against the basement membrane. So it's directly damage to the basement membrane. And again, it leads to the subepidermal. So below the epidermal, subepidermal blistering, again, pemphigoid will also associated with the scarring formation. Now, when we talk about the last condition in this chart, which is called toxic epidermolysis necrolysis, which is called TAN, okay? So TAN is again mediated by staphylococcal infection, okay? And you see, infection could be due to medication, like Steven Johnson, TAN. So it could be infection due to infection, medication, could be due to malignancy, leads to the apoptotic keratinocyte cell death in the epidermis. So basically it involves your corneal layer, okay? Apoptosis of the keratinocyte cells. Keratinocytes are the one which is stratum corneum, okay? With bullous formation due to the dermal epidermal separation as well. So over here as well, the cell basically involving the dermoepidermal junction involvement. Okay, so that is why it also leads to the scarring. So in the Steven Johnson and in the toxic, again the dermal epidermal separation or junction is involved over here. Okay. Another important thing, they basically ask about the level, okay? But you can see the manifestations, clinical features are, in the bullous disorder, they are very similar. But you can see over here, mostly you can see the generalized blister, mucosal involvement, blisters are there. So you just notice over there where the mucosal involvements are more common. So if you talk about the pemphigus, you can say pemphigus, the epidermolysis bullosa simplex, they are the pemphigus vulgaris. You can see that there are less, the systemic involvement in this case, which is superficial. When we talk about the deeper ones, the junctional, the dystrophic, it will involve more systemic involvement, more mucosal involvement. So you can see dystrophic also systemic. The junctional is also with the systemic involvement with the mucosal involvement. So that's why they need multidisciplinary team management. Okay, so they need multidisciplinary, especially if you have, the system is involved. So you need multidisciplinary. Otherwise, for autoimmune condition, the main treatment of line is your antibiotics. And if it is bullous impetigo related to the infection only, then you can give antibiotics. Otherwise, in all the autoimmune related condition, the main role is the immunosuppression, that is steroids. Okay. Now back to our scenario. So we will going to solve this scenario quickly. So we have discussed in which layer of the skin the pathology is there without scarring. It's the epidermis. The following is the list of the layers of the skin. So these are the all layers of the skin which we just talked about it. Now say we match the condition in which it's involving. Okay, so now you can easily match it, that if it's talk about the dystrophic epidermolysis, so it's dermoepidermal junction is involved. Okay, when we talk about the bullosa simplex, okay, so epidermolysis bullosa, if you can remember, it's the basement membrane is involved, and the spinosum layer, okay, which is basically involvement of the tonofilaments, if you can remember it. Okay, so you can over here, it will involve the stratum basal layer and the spinosum, but most likely the basal layer. Okay, when we talk about the pemphigus vulgaris, so I've already mentioned that vulgaris is a desmoglein 3 protein is involved, so that is why it involved the stratism spinosum layer. Staphylococcal scalded skin syndrome is a superficial skin layers are involved. So the most likely the superficial skin layer which is involved over here is the this granular layer, okay, stratum granulosum layer. Now when we talk about the toxic epidermal necrolysis, we just talk about the 10 10 is again involving the dermo-epidermal junction. Okay, so if you can remember the 10 in the chart, this is 10 and staphylococcal scalded syndrome. Not staphylococcal scalded syndrome, sorry. The 10 and the Steven-Johnson syndrome, they're basically involving the dermo-epidermal junction is involved. Okay, so we have already discussed these points. Okay, and now we'll talk about the another case, which is the baby, a boy with the eczema. Okay. Now, this is the 4-year-old. So now we talk about where is the problem in the eczema as well. So we have finished the bullets part. Okay. So eczema, if you let's start with this case. It's actually you can say, if you talk about the mode of inheritance of the eczema. So just like the pyloric stenosis, it's multifactorial. So many factors are involved in it. Genetic also play a role, environment also play roles, and the triggering factors, the triggers, these also play an important role. So it's a 4-year-old is sitting outside the clinic room waiting to be seen. He's scratching at his excoriated arms. You can see his skin is lichenified. So what do you mean by lichenified? Means thickened skin, brown color skin, that is called lichenified. He's keeping his family up at night. So the scratching is so much that he cannot sleep properly at night due to the scratching and being generally uncomfortable. He's attending for follow-up review after admission for eczema herpetic. So the eczema herpeticum is actually caused by the herpes infection, and it is more likely to involve the skin which is already having atopic condition or having other dermatological conditions. Okay, so eczema herpeticum normally does not occur in the healthy skins. Okay, his brother is inpatient in the ward. You can see that there is a brother. He is inpatient with asthma, with the eczema, and with the ichthyosis vulgaris. Okay, so you can see over here in the history that in the family, the brother is also having asthma. So atopy is running, asthma, eczema, and ichthyosis vulgaris is also there. Ichthyosis vulgaris, I think, for let me search about it. Ichthyosis vulgaris, I think the dry skin. Let me search about it. I just forgot. Ichthyosis, ichthyosis vulgaris. So ichthyosis vulgaris is basically a common genetic condition causing dry scaly skin, okay? Causing dry scaly skin due to the buildup of skin cells and do not shed normally, okay? So this is the picture of the, let me show you the picture of the ichthyosis vulgaris. I'm just sharing it, just a second. This is the picture of ichthyosis vulgaris. Okay, can you see this condition over here? See, this is called ichthyosis vulgaris. So it's a scaling condition, buildup of the cells which do not shed. Okay, dryness, itching, white brown scales of the of 10, and severe on the legs. There is no cure. Can be just managed by moisturizers, exfoliators, and avoiding harsh soaps or the irritants. Okay, so this is called ichthyosis vulgaris. Now we back to our class. Okay, now what they're asking that concerning these children's, which one of the following statement is most accurate? Children with eczema have thickened skin, which reduces the permeability. Ensuring dry, cold environment in the home will alleviate the eczema. No, the dry environment will going to aggravate. It will not relieve the eczema. So false is the B option. Reduced barrier function. Yes, this is true. Reduced immune activity in the eczematous skin. True. Tacrolimus block calcium independent protease. No. Tacrolimus is a calciurine inhibitor. So this is wrong. What about the A? Because of the thickened skin, that reduces the permeability. That could be right. Okay. So A could be right. B is absolutely wrong. C is also right. D is also right. E is false. Okay. Now they're asking about which one of the following statement is most accurate. So most accurate is the C one. Most accurate is C1. Reduced barrier function of the skin predisposed to the infection. So they have multiple predisposition to herpes infection, to the bacterial infections like strep, staphylococcus, to the folliculitis and everything. So I think the best thing is the C is would be the most accurate. Okay. Now, when we talk about the next question, the skin is a complex organ. Intra and extracellular proteins interplay to support skin function. Match the protein and organelle from A to J in the described. So what will lead to the attachment to the basement membrane? We've already described that attachment to the basement membrane is through the desmosome, destroyed in the staphylococcal scalded syndrome. So that is destroyed in the staphylococcal scalded syndrome is your desmosomes. Okay, hygroscopic to maintain water content of the skin. So who will going to maintain the water content? It is the flagrine protein. That is mainly involved in the atopic dermatitis. That is why our water content of the skin got disturbed and we have excessive dryness, and the dryness will leads to the itching. Main constitute of the cytoskeleton in the stratum corneum, the uppermost layer is the keratin. If you can just recall that the uppermost layer is keratin. Okay. Now we talk about the function. Flagrant, as I mentioned, where the flagrant is found, it is found in the granular layer. So I just show you the granular layer, which is just below the, the corneum layer, which contains so many granules. So what they are saying, flagrant is found in the keratohyalin granules. These granules are present as the cell migrate from the prickle layer into the granular. So the granules are basically contain the keratohyalin protein. Keratohyalin, okay? It is within the granular cell layer, the terminal differentiation will going to occur, okay? So the last stages will going to occur in the granular cellular layer, okay? So if I show you the picture over here, so you can see the first thing is that this is our stratum granulosum layer and how the things are going on. So you can see that this is the nucleus and we have granules, and in the granules we have these keratin filaments, and along with that these circle like structure is called keratohyalin granule. So this is the structure of the granulosum cell. It contains one nucleus, it contains these keratohyalin granules, and it contains the keratin filaments. Okay, then what would happen initially that once these keratohyalin granules will going to further break down, they will go see this is the keratohyalin molecule. What is the structure in it? It contains the proflagrant protein. Initially, the flagrant protein is pro form. It bounds to the certain protein region. Then you can see the breakdown, the proteolysis will going to occur, and you can see this flagrant is separately occur, separation of the flagrant and occur. And what is the flagrant? Flagrant is the one which contain the water content. So as it goes in the upward cells, you can see in the corneum, what would happen in the last layer, that these keratin filaments, they are bound with each other with this flagrant molecule. So keratin and the fligrin, they will going to make this type of complex that would associated with the stability of the cell. The hygroscopic content is there, the water regulation and everything is there. So in that way, from the granulosum layer to the corneum, this whole differentiation will going to occur. Okay, so now you will going to understand it. It is within the granular layer the terminal differentiation occur. The major content of the granular layer is the keratohyaline granules, which basically the granules which are keratin. Okay, granules are keratin and the profligrin. So two things are there inside it. Okay, so two things. If you look at it, keratin, these keratohyaline granules, it contain keratin and profligrin. Profligrin is the pro molecule of the fligrin. As the contents of the granules are released, keratin forms long polymers called tonofilaments. So tonofilaments will be formed by the keratin. Profligrin is released from the granules, broken down by the action of proteases enzyme into fligrin. Then this fligrin molecule will going to cross-link the keratin tonofilaments. Cross-link keratin provides not only the structural strength to the cornified cell, but also form the outermost part of the skin. It is cross-linked keratin that forces the originally cuboidal epithelial cell into the squamous shape. The effect of the fligrin far outreach the structural integrity. So it's not only give the structural integrity, it also involving the moisturizing action of the skin, antibacterial activity, and possibly the photoprotective effect. So this fligrin is basically involved in the asthmatic peoples. Okay, so fligrin is basically hygroscopic. It absorbs and holds on to water molecule, becoming a hydrated molecule. Fligrin is degraded by a proteases. Okay, okay. So it's hygroscopic. Fligrin is degraded by the proteases, amino acids. Okay, and then this fligrin is further degraded by proteases, amino acids released, which further add to the moisture retaining properties of the stratum corneum. The loss of water from these molecules is higher in the dry environments and promotes fligrin breakdown or turnover. So in warm, humid environments, there is less water loss from the hygroscopic molecules, leading to improved skin stability. Fligrin and its degradation products, along with the lipids present in the squamous cell, referred as a natural moisturizing factors. Fligrin degradation fulfill another important role. Resulting amino acid breakdown will lead to the low skin pH, okay? Suppress the bacterial growth, and some of the degradation products have direct anti-staphylococcal effects. Studies in fligrin knockout mice show that the degradation product also contributes to the protection of the skin from the ultraviolet radiation. The most common conditions that involve the fligrins are the ichthyosis and the eczema. So I just show you these are the two conditions that will involve. So this is exam question. They specifically ask about that which structure is involved in the eczema. Both these conditions are exacerbated by the cold, dry weather. Ichthyosis vulgaris is caused by loss of function mutation in the fligrin gene. So loss of function means no fligrin is produced, completely absence of the function of the fligrin. Loss of function mutation in the fligrin gene leads to at least threefold increased risk of having atopic eczema. Fligrin is most common gene defect associated with atopic eczema. Eczema herpeticum is more likely in patient, as I mentioned, with flagrant defect. So eczema herpeticum is mediated by the herpes virus. Eczema treatment such as emollients and wet wraps increases the humidity close to the skin, boost its water retaining qualities. This slows the flagrant degradation and leads to a significant clinical improvement in the eczema. So the main role in the eczema is your moisturizers, okay? So whatever the breakdown in this barrier function for any reasons leads to increased absorption of substance across the skin, easy passage of microbes through the skin and increased water loss from the skin. Skin then become dry and itchy, more rapidly shedding of the squamous from the stratum corneum, giving observed clinical feature in the eczema and ichthyosis. Loss of acidity and structural integrity allow invasion of the skin by microorganism and leads to infection. Other substances are also more likely to traverse the outer layer of the skin, can then come into direct contact with the immune system. This is the mechanism by which eczema can lead to allergic sensitization. Once a innate immune system is exposed to new allergens, immunological memory can be formed, and after the repeated episodes, exposure will lead to inflammatory response. The inflammatory response caused by absorbed allergens can lead to a clinical picture of eczema. Once inflammation has occurred, then you need immunoregulators like steroids or calcineurin, not the calcium. It's the calcineurin inhibitor, which is tacrolimus, is needed to relieve the symptoms. So when we talk about the pattern of atopic dermatitis, it is different in, infants. It has different, distribution. In older children, it has different distribution, and even in adults, different distribution. Okay, so in the infants, the most likely you can see that it's the involvement of the cheek and the scalp area will going most likely to involve. And you can see in the infants that most likely it is this extensive surface will going to involve. Okay. So where will be the findings in the infants? Predominantly it was the face, scalp, and also the trunk, and in the limb it is the extensor surface. But if we talk about the older children, it is predominantly the flexor surface. So you can see this flexor surface, this behind the knee, this flexor surface, these flexor surface are more commonly involved in the older child. So the distribution will going to vary according to the age. And if we talk about the adult age, now these parts will going to improve little bit, and their involvement of specifically hand involvement, hand dermatitis will be the older manifestation of the atopic eczema. Okay. Now, the another case with the eczema, and over here we are talking about a case with the eczema herpeticum. Okay, so before we talk about this case, let me take a namaz break over here for 10 minutes. Okay, I'll be back at 6:30. Okay, 15 minutes break. So 6:30 I'll be back, and then we will continue the further part. Okay. So just taking a namaz break at this point. Okay, we will going to do the another case of eczema. Again from your book, Out of Control Eczema. Bala is a 5-year-old boy who present to the emergency department with 2-day history of deterioration of his eczema. Okay, so eczema deterioration could be a exacerbation as well. Okay, his parents explains that he has been constantly scratching at skin. So whenever there is an inflammation is going on, whenever there is a deterioration or exacerbation going on, so you have a lot of scratching occur. Okay, on examination he's very miserable. So but miserable child is not a finding of not only a normal, you can say that normal deterioration of the eczema. You will not find the miserable child. So miserable means that there is a systemic involvement is there, cervical lymphadenopathy. Okay, he has a widespread erythematous and excoriated rash. There are also areas of vesicles, crusting, and punched out lesions, mainly affecting his arms and legs, and also some lesions in the periorbital area as well. His heart rate is 100 and temperature is 36.4 degrees centigrade. His parents have been applying regular emollients and hydrocortisone cream. So if it is simple deterioration, it should improve with the steroids. So they are already applying the emollients and hydrocortisone cream. However, this has failed to improve. On further questioning, he reveals that his sister has been suffering with painful erosion of the upper lip. So there is a exposure with the herpes. So this painful erosion of the upper lip is most likely the herpes type 1 stomatitis. Okay. Okay, next we talk about a question, which is the most appropriate investigation to confirm the diagnosis of eczema herpeticum. So for that, we need a viral skin swab. Okay, so that would be most diagnostic in diagnosing the eczema herpeticum. What is the most important treatment for the above patient once a clinical diagnosis of eczema herpeticum has been made? So this is a child presented to you with miserable, but there is no fever is there. Okay, so definitely you will going to start acyclovir. But if it is a systemic involvement is there, then you need IV acyclovir. So in this case, because there is no systemic involvement, fever is not there, so you can give the child oral acyclovir. Okay. Apart from the dermatology team, which of the following is most important to be contacted? So because of the involvement of the eyes, you need ophthalmology also, because herpes can lead to the corneal scarring as well. So that is why you need a proper eye follow-up as well. So along with the dermatologist, you need ophthalmologist as well. Okay, so we have discussed. Now when we talk about the eczema herpeticum, it's in, yes. Why not topical? No, acyclovir always you will be given either oral form or IV form. Okay, it's not the acyclovir we don't give as a topical forms. Okay, so it's a debate with oral or IV use. Such a severe infection throughout the skin. Okay, it's not a localized. So that is why you most of the time, even with the gingival stomatitis, when there is entire involvement of your gingiva and your stomatitis, again you are giving oral forms. Okay, so oral versus IV is the main issue. Okay, eczema herpeticum is caused by infection of the skin by herpes simplex, which can be severe and life threatening. So this is a very severe and life threatening. One is more common compared to the two. Children of all ages and ethnic group can be affected, and highest incidence in those with age 2 to 3 years. In most cases, the patient is known to have history of eczema. So in most cases, there would be the underlying history of skin involvement. It usually presents as deterioration of eczema accompanied by pain, lethargy, and systemic upset. The rash of eczema herpeticum is vesicular, often with crust and punched out lesions that can coalesce. Any cutaneous site can be affected, but more commonly it involves the limb. For the confirmation, you need viral swab should be taken, and the most important investigation when BALA first presents. Severity is highest in the first 24 to 48 hours after an active vesicular lesion has appeared. Serum viral PCR is more sensitive and has good specificity, but it is not usually necessary due to cost implication. So we can perform serum as well, but because of the cost implication, we are not performing it. Okay. Bacterial swab should also be performed, as co-infection with the Staph aureus can also complicate the eczema herpeticum. Baby should be referred for urgent dermatological opinion, and treatment started immediately. The most important treatment is for the herpes is acyclovir. If the child is systemically unwell, they should be admitted for IV and fluid replacement. However, if the patient is systemically well, acyclovir should be given orally. It is important to start acyclovir sooner rather than later and should be done so while awaiting virological confirmation. The recommended course duration of both IV and oral is 5 days, although sometimes you need longer courses are needed. Patients who are immunosuppressed require higher doses. Other supportive measures include pain and fluid also be given. Children are advised to be cautious with the use of topical steroids in eczema herpeticum. So in the eczema herpeticum, you will cautiously use the topical steroids as their use can potentially worsen the condition. So initial treatment should only focus on antiviral plus minus antibacterial therapy. Periorbital involvement require urgent referral to the ophthalmologist to look for the corneal ulcerations. Okay, so this point we have discussed why we go to ophthalmology. In the children, atopic dermatitis or eczema most commonly an earliest sign of atopy. So atopy is basically what I explained you. It's the umbrella. It contains 4 to 5 conditions under it. It all starts with the atopic dermatitis, asthma, allergic rhinitis, food allergies. So everything come under this umbrella. Now the first thing is the eczema. It is the early presentation. It present just in the neonate is the involvement of the cheeks, involvement of the scalp. This is the most earliest. Asthma comes in a childhood phase more, okay? So this may be followed later on. You could have allergic rhinitis, asthma, allergy on all will make it as a atopic march. Okay, so atopy is you are reacting to a substance in which most of the people do not react with it. So you are basically reacting to the inert substances. Okay, the discovery of a loss of function mutation gene that encodes flegrin had led to a much greater understanding about the pathophysiology of the eczema. Flegrin, we have already discussed, is an important epidermal protein expressed in the outer layer of epidermis, play a vital role in skin barrier function. Flegrin gene mutation ultimately result in the definition of flegrin, and this is known to play a critical role in the development of atopic dermatitis. The clinical diagnosis, it's a clinical diagnosis, another important. You don't need any investigation. How you will going to diagnose? History of ill-defined itchy. So you find that there will be ill-defined everywhere itchiness, and then followed by itchiness you would have erythematous patches. Most commonly, its distribution is depends upon the age related. So flexural areas are more common involved in the childhood, although the non-flexural areas are often, especially in the younger children, with the family history of the atopy. So the treatment is atopic dermatitis should be offered unperfumed emollients to be used on daily basis, especially after bathing. Okay, so after bathing, it's very important that you should apply moisturizer. Daily basis pe you will going to apply the moisturizer. Okay, they act by providing an effective barrier layer over the skin, decrease moisture loss and protecting against irritants. There is a wide range available and choice should be decided by your dermatologist. Then after the moisturizers, you will going to use topical steroids. This is another at the time of inflammation. It's important treatment. They should apply on the area of active eczema at the appropriate strength. Appropriate strength means you can see that we have different strength available. We have mild potent steroids, we have moderate, and we have most potent as well. Okay, so this is also commonly asked in the exam. What is the you can say that the arrangement, or you can say that from mild to moderate, how the steroids are categorized. You should remember it that the milder is hydrocortisone, then the moderate is your clobetasone, S-O-N-E, sone. Then top most potent is betamethasone and clobetasol. So clobeta, S-O-L-E, sol. So that would be most patent. This is commonly asked question. Okay, so you should know you have to give appropriate strength. If you are giving on the face, you will give mild potent. If you are giving on the limbs, you can give potent steroids as well. As a general, topical steroids settle eczema. You can give twice a day for just 5 to 7 days and then reduce the frequency of application, or you can reduce the potency as well. Area of the crusted or infected eczema may respond better to steroids, antibiotics, or steroid antiseptic combination. Local side effects of the steroids like telangiectasias on the skin stria can be minimized if you will going to use appropriate steroid strength. Okay, so this is very important that you should know about the strength of the steroids. Now, sometime in the scenario, it is mentioned that the mother will come to you and she was using a mild potent steroid on the face, like hydrocortisone, and the treat because of that treatment, the rash is not settling, and mother is fear of having giving high potent steroid on the face, so she does not want any steroids. So in that case, what you will give as an alternative, so as an alternative, a second or third line treatment, you have calcineurin inhibitors, that is tacrolimus, and these pimecrolimus. Okay, so limus is the last word. As recommended as the second or the third line, moderate to severe eczema, licensed in patient over 2 years and older. They do not cause any skin thinning, although these use with the specialist interest in the dermatology. So this will only be given by the dermatologist. Okay. Some patient may require regular application of dry or wet bandages to occlude topical treatments and help improve acute flare-ups if available. This can be organized through a specialized departments. Okay. Psychological aspect. So what happened that because it's a chronic condition, asthma, it's lifelong condition, it's come up with the exacerbations and improvement. So sometimes you have a bad psychological impact as well because of the involvement of the skin, sometime because the multiple due to chronic inflammation going on, you have lichenification that also have a psychological impact, especially if there is a face involvement. So that also sometimes you need psychological help as well. So you see the moderate to severe eczema has significant impact on the quality of the patient and their family. Itching, scratching, sleeping deprivation on one hand, and have a negative impact on the psychological well-being. In addition, regularly application of topical treatment is also time consuming. It is therefore important to educate the patients and their carriers about the importance of regular application of topical treatment to prevent flare-ups and avoidance of the known triggers, that is the triggers. Okay, so asthma is now finished. Now we talk about something related to the burns. Okay. Okay, so different types of burns: superficial, deep, partial. So now we will talk about those. Okay, a 9-month-old attends the emergency department by the ambulance with the 8 centimeter by 3 centimeter burn on the top of his right thigh. Both mom and Archie are extremely upset. The paramedics told you that on arrival to the house, mom was holding the infant leg under the cold tap. En route, they had covered the wound by cling film. Mums tell you she had fallen asleep with Archie in her bed and woke to find Archie crying hysterically, having rolled into a small gap between the radiator and the bed. MMG extracted him. She noticed a burn to his leg, so put it under the tap. Archie was given some intranasal diamorphine and the burn is examined. He has an oval burn running down the lateral aspect of his left leg from just below his nappy line to the knees. Within it are 2 long fluid-filled blisters with surrounding erythema. The blisters were de-roofed and the burn is dressed, and Archie seems to be happier. Okay. So which one of the following statement is correct? Select the one answer only. Okay. Cellular skin damage occur once the skin temperature reaches beyond. So we will talk about the certain temperature, but this is false. Contact burn cause more injury than the scalds. No, scalds, the water injury is more severe, more penetrating as compared to the contact. Destruction of the retipex in the epidermis has leads to the blistering. Okay, retipex is the supporting part which connects the epidermis to the dermis. Okay, it's not about the retipex destruction that leads to blistering. The zone of coagulation is less likely to part of the burn to be infected. So we talk about different zones and then we will conclude this point. Thermal inertia is provided by the Meissner's corpuscle. So this is right, that inside our skin we have different corpuscles. So the thermal inertia or the thermal, the sensation of the temperature is mediated by the Meissner corpuscles. One answer is E is right. Which when scarring, if burn is deliberate, if you think this is the deliberate, which one of the following is true? Burns are varying depth. So whenever there is a varying depth are there, this is most likely accidental. Varying depth, okay? Child protection evidence is limited due to paucity of a published literature. Child burns are rare. No, it's not rare. Evidence heavy, a lot of evidences. Most intentional burns are scalp. This is right. That you will going to dip into hot water, hot oil. So most intentional or non-accidentals are scarred one. The battered child was first described in 1950, so the answer is 1960. Now, when we talk about the burns occur at all ages, but the toddlers are at the highest risk. So, those who are toddlers, they are at the highest risk and highest overall rate of the burn injury due to the combination of their increasing mobilities, their curiosities, and their lack of life experiences. The risk is amplified if motor skill development outpaces the cognitive. So if there is no cognitive development, if they don't understand anything and motor skills are there, they can run. So in that way, they can damage themselves, okay? So cognition is also important, okay? The severity of the burn depends upon the burn depth, the size, the location, and the patient age, with infants and elderly having been the highest mortality rates. The depth of the heat injury depends upon the degree of the heat exposure, okay, and depth of the heat penetration. Water heat travels more rapidly. As I say that the scalds burn are more dangerous than the dry flame because water conducts heat 2 times more efficient than the air. In addition, skin thickness is also crucial. The thinner the skin, the deeper the burn will be. It takes only quarter of the time for a child to sustain a scald compared to an adult. So children have thin skin, so they will get in a quick time they will get a large burn. Okay. Contact with hot objects is the second most common occurring burn mechanism in small children after scalds. So scald is the most common. After the scald, the contact with the hot object. When a hot object you touches the skin, the equilibrium temperature is dependent on the thermal inertia of both the object and the skin. Thermal inertia is related to the thermal conductivity. You are conducting the heat, density and specific heat and the original temperature differences between them. Skin damage occur once the temperature is greater than 49. Contact burns are usually small and require object to either be very hot, unlike in a domestic radiator, or for a contact time to be abnormally long. Normally, what happens in the contact burns that whenever you touch the hot object, you suddenly remove it. So your contact time would not be so long. So whenever, what are the chances that you require a significant contact occur? Either the object is very hot or there is a contact time is long. Okay, this might occur if the child was trapped between an object and the radiator for a period of time. The normal reaction to the painful stimulus is withdrawal, which limits the contact time in most of the contact burns. Okay. Burn depth is anatomically defined by how much of the skin surface is involved. Okay, so in the superficial burn, it's confined to only epidermal layer, outer epidermal layer, which is occur in the sun burns. When we talk about the partial thickness burns, that involves the epidermis and the part of the inner dermis. And partial thickness are further divided into superficial partial thickness, that destruction of the entire epidermis, and no more than 1/3 upper third of the dermis. The microvessel perfusing this area are injured, leading to the leakage of large amount of plasma. This lifts off the heat destroyed epidermis and causing blister to form. So blister is not due to retipex. It is basically the damage to the microvessels that leak out all the plasma, and because of leaking out of that plasma, that causes blisters to form. These are the most painful burns as the nerve endings are exposed to air and they look pink and the wet. So they are pink and they are wet. When we talk about the deep partial ones, that involve the destruction of the most of your dermal layer. So in the deep partial, most of your dermal layer, but only you have few viable epidermal cells remain. Blisters do not tend to form as the dead tissue layer is thick and adheres to the underlying viable dermis. So in the deep partial thickness, you would not have blisters. So blister is a characteristic of superficial partial thickness burn. So in the simple, if we talk about superficial burns, you don't have any blisters. Blister is a part of superficial partial thickness, okay? So they are white and dry. They are not pink, they are white and dry, but do have some sensations. Though pain is reduced as many nerve endings have also been destroyed. When we talk about the full thickness, that involves the destruction of both dermis and epidermis, leaving residual epidermal cells to leaving no residual. So it's basically a mistake, leaving no residual epidermal cells to repopulate. So they are painless. Okay. Subdermal means involve the destruction of both layer and extend into the subcutaneous fat, into the tendons, into the muscles and bones. Okay. Now we talk about the thermal injury related zones. Okay, with three zones are there. You can see the center zone is the zone of coagulation, which is shown with the black color. Then we have the zone of stasis, which is with the maroon color. And the last, the outermost, is the zone of hyperemia, that is red in color. So we have, due to the thermal injuries, we have these three zones are there. The area of the superficial injury, the area of superficial injury, so in the superficial area, superficial is the most is the zone of hyperemia and it is warm and red. Middle area is the zone of stasis where the microcirculation is damaged and changes in the capillary permeability allow fluids to leak from the vascular system into the interstitial space. This is called zone of stasis. The deepest is the zone of coagulation where heat damages the cell and occluded the blood vessels, and because of the occlusion there will be necrosis. Okay, this obstruction prevents the humoral component of the immune response from reaching the burn tissue. Transference of heat by liquid result in a greater zone of stasis. So when there is a damage by scarred injury, you would have a big greater zone of stasis. This zone will evolve. They're talking about the zone of stasis. This zone will evolve over 72 hours, resulting in the more significant injury than on the first assessment. This potential for continuing burn has to be taken into consideration, especially when you are managing the scarlet injuries. So they will going to evolve more over with the time. Okay. So I think we have covered, we are left with certain topics. So we will inshallah cover the remaining part inshallah tomorrow. Okay. And tomorrow we'll again continue at 5 p.m. Park inshallah. Okay, we'll finish this inshallah dermatology and we will start a new system inshallah. Okay, and I've sent a dermatology PDF as well. You can just look over it quickly. They are more relevant for the AKP exam, but you can just look over it quickly. They don't ask too much about it from the dermatology. One or two questions are coming, but still there is no need to read too much books. Just cover these cases along with those PDF would be enough for it. If you have any questions regarding dermatology, you can ask it up till now. Okay, so if there is no questions, then inshallah continue tomorrow at 5 p.m. And we will finish it inshallah tomorrow. Okay, Jazakallah. Thank you so much.